Moving on to metastatic disease. Metastatic disease of the hip is very common. Quite often the cause of metastasis to the hip is the breast, but usually all the usual suspects for bone mets are also included.
With the truth here, good host bone contact. You need to get really good at, again, good initial test fixation. I haven't done that. I've done a human personally. Don't forget, you can do an anterior capture on them too. That also improves your ability to do this. Taking away the acetabulum, unless you can be sure where the margin of the acetabulum is, taking away occupied, but then taking away more than that makes it a little harder. I know the stated problem, but it can occur.
Okay, so in metastatic disease of the hip, quite often 70% of the patients are living more than 6 months. So it's usually the rule to treat them aggressively because improves their mobility, decreases pain, and improves their quality of life, which is important in patients with cancer. With meds to the proximal femur, it's relatively uncomplicated to treat. With either a hip replacement of some sort or internal fixation to stabilise the fracture. But in acetabular lesions, the reconstruction is quite a lot more difficult. Harrington's described in his paper in 1981 4 classes of involvement of the acetabulum. Class 1, essentially all the walls of the acetabulum are intact, and there is only a minor defect as a result of the metastatic disease. In class 2, there's a medial wall defect, and in class 3, the lateral wall, the superior wall, and the medial wall is deficient. Class 4, which is really not a logical step, is a lesion where you can treat with a curative intent with a non-block resection. In Harrington class 1, again, you can treat this with a conventional total hip replacement, cemented both acetabular component and femoral component, because all the walls are intact. In class 2, where the medial wall is deficient, the use of a cage or an anti-protrusio shell or other augmented fixation devices would be appropriate. Class 3 is a different kettle of fish. So basically, quite extensive involvement of the acetabulum, so that when you debridal the tumour, what the bone remaining is not enough to support the acetabular component with or without a cage. So what Harrington described was to insert threaded Steinmann pins retrograde into the ilium and through the sacroiliac joint to act as a strut to support the acetabular component in normal bone. So once these threaded Steinmann pins are inserted, they put in 1 mix of cement, which incorporates the stum and pins and leave a cavity in the cement. And then they put in an acetabular cage and the acetabular component and cement that in using a cement-in-cement technique. Now, a lot of other authors have described a variation on that technique, which includes, for example, an antigrade insertion of the stum and pin, or using cancella screws instead of the stum and pins, but the principles are the same. The other points with metastatic disease is that use of bone graft is contraindicated simply because the bone's abnormal and there's a high risk of the bone not incorporating, and quite often these patients will go on to have adjuvant radiotherapy. My next area of discussion. So post-radiation, radiation in the pelvic region is common in gynecological cancers, and usually the patients receive between 30 and 50 gray of radiotherapy in total, and the threshold for cellular change in cell death is 30 and 50 gray respectively. The radiotherapy effect on bone is as below. You get osteoporosis, there's fibrosis of the bone marrow, there's microfracture in the trabecular framework, and there are multiple small areas of disseminated necrosis. In addition, there's a vascular injury, which can lead to wall thickening and occlusion. So the bone has an impaired ability to repair itself and becomes brittle because it's not able to withstand normal stresses. Because the acetabulum is quite close to the region of radiation, it's quite often involved. There is the delay or the latent period between the radiation and symptoms are quite variable in patients, but when the symptoms develop, they tend to develop quite rapidly, unlike in primary osteoarthritis of the hip. There is a high rate of failure of the acetabular component. Masson and Duparc in 1995 demonstrated 52% failure rate after 69 months in patients with cemented acetabular component. That was slightly improved using an acetabular cage, but the follow-up was only 40 months. And Jacobs in 1995 used uncemented acetabular components, and there was also quite a high failure rate in that study as well. There is some promise with the tantalum porous coated cups. The benefit of the tantalum cup is that it's got a high coefficient of friction, and it's got improved biological fixation. And the early follow-up published in 2006 by Rose showed that after 31 months, which is quite an early follow-up, there wasn't any failure. So it's lastly, acetabular fractures. There are three situations where you perform a total hip replacement in acetabular fractures. The first situation is treatment of the acute fracture. Second situation is for treatment of failed non-operative treatment, and treatment for failed operative treatment is the last situation. In the acute fracture, in which total hip replacement is performed, the indication for acute total hip replacement includes extensive comminution, where there's significant impaction of both the femoral head and the acetabulum, and in patients who are old. The advantages are that it's a one-stage treatment, but the disadvantages are that it's technically very, very challenging. Not only do you have to ensure that the socket's stable, you actually have to make sure that the fracture is stable as well. Usually an uncemented cup is used with augmented fixation with screws, plates and cages, etc. For the treatment of failed non-operative acetabular fractures, the challenges are really similar to what you get in a revision setting. There's pelvic deformity, there's at times malunion or non-union, there's bone loss, there's distorted landmarks and difficult exposure, and there's a higher rate of acetabular failure in doing hip replacements in these settings. So I think Professor Bergman's going to talk about the revision setting, but you use a standard approach to reconstructing defects using, for example, the Academy of Orthopaedic Surgeon classification or the Poposky classification. Cases where there's previous internal fixation, you face the same problems as you get with a non-operative treatment, but in addition, you actually have to deal with the sequelae of surgery, and that includes scar tissue, heterotopic ossification, and the presence of internal fixation devices. So again, a similar approach to the revision setting, but in addition, you have to look at removal of metal, which can either be selective or complete, and dealing with heterotopic ossification and scar tissue. The last thing I'll talk about is hip fusion. Now, hip fusion can be either spontaneous or can be post-surgical. Spontaneous ankylosis can be caused by a number of conditions, including post-traumatic, post-infectious, as a result of ankylosing spondylitis or advanced arthritis. Quite often the indications for conversion of a fused hip to a total hip replacement is pain in the adjacent joints, most commonly in the lumbar spine region, secondly in the ipsilateral knee, and then in the contralateral hip. Rehabilitation under these circumstances are quite prolonged. The functional scores peak at about 2 years, so a lot longer than a primary total hip replacement. The risk factors for an early failure of a converted ankylosed hip include a previous arthrodesis, a surgical fusion, any previous surgery to the hip, patients who are of younger age, and patients who've had their fusion for a long time. The functional outcome after converted arthrodesis, really, especially the mobility, actually depends mainly on the abductor function. So, and quite a lot of authors actually advocate assessing the abductor function before embarking on converting a fused hip to a total hip replacement. So that's Mr. Bergman. Do you have anything else to add with regards to conversion of an ankylosed hip? I do understand that the issue of, it's more an issue of approach and the soft tissue rather than bone stock.
Yeah. I mean, whether or not to down. We will take down after these. I do try and assess the abductors and
So just to kind of finish up, so basically the approach to acetabular reconstruction, the aims you're trying to achieve, pretty simple, but quite often it may be very challenging to achieve those aims. That is to restore the center of rotation of the hip in an anatomical position, primary fixation, and long-term integration of the implant. What I've taken away from it is going into these kind of surgeries, you need to go in with your eyes wide open with good preoperative planning, relevant clinical assessment, X-ray, CT and MRI, and use a systematic approach to reconstructing the acetabular defects. You need to cover all bases. That includes having all the appropriate implants, special equipment, bone graft, and quite often you might have to order it in the kitchen sink, and have a plan B.